Okay, welcome back to another lecture. Today we will be going over Chapter 15, Medical Overview. So just to kind of make everybody aware, this is going to be a chapter of just a very kind of top-down view. It's very quick. We're not going to be going into depth on topics. It will bring up several different, more encompassing topics as we work through, especially once again on the medical side. So just don't be surprised when I don't go into detail quite yet. Those will come with the other chapters that are associated with the conditions we talk about. Now, with that said, let's get rolling. So, patients who need EMS assistance generally have experienced a medical emergency or trauma emergency or both. Now, trauma emergencies are going to involve injuries resulting from physical forces applied to the body, right? So, kind of a generalization on that blunt or penetrating trauma, right? They get hit by something, they get poked by something, right? And that poke being entering the body at whatever degree. Medical emergencies involve illnesses or conditions caused by diseases. So we're going to have our mechanism of injury for trauma and our nature of illness for our medical. Now, in reality, this very much applies. You will have to kind of make the choice. Did the car crash cause the heart attack, or the heart attack cause the car crash, or vice versa, right? When you're in school, that's not the way it works. Can't speak to every program, but here locally at our program, what we will do is when you're going into your assessment, your testing times, you will know this is a medical scenario, this is a trauma scenario. It is going to be very separate. They're not going to start blending. Now understand, this is where school can kind of maybe offer a disservice to you if you get into that one lane kind of mentality. This is going to only be medical, this is only going to be trauma. Real life, there's a blending of both. It's not uncommon for medical conditions to lead to trauma. If we think about it, it's things just as simple as falling down. But moving on, so type of medical emergencies. So working our way through the systems of things that we might run into. First one are respiratory emergencies, right? So breathing issues. Patients having trouble breathing or the amount of oxygen supplied to the tissues is inadequate. The concept, if you've gone through shock at this point, but the concept of hypoperfusion starts to come back, right? This is, if you think about perfusion generally, every single concept in this field, our goal is to reinstate perfusion, right? We want to get blood supply that has good oxygenation to all of the tissues. We are actively fighting against the things that don't give you that. Okay, so moving forward, cardiovascular conditions affecting our circulatory system. So cardio, heart, vascular is going to be the circulation or circulatory system. So cardiovascular can be a blending of both. It can be a heart problem, it can be a vessel problem, or it could be both. It really just depends on the complaint. Neurologic emergencies involve the brain. I would expand this a little bit. Now, maybe more so into the trauma realm if we think about it, but neurological emergencies involve the brain as well as the rest of the nervous system. Anything that's affecting central nervous system, peripheral nervous system, all of those could be potential neurologic emergencies we run into. For GI, appendicitis, diverticulitis, pancreatitis, and many others, GI gastrointestinal conditions is a very wide range as well. There's a lot of conditions out there. Now, also understand, going over just once again the medical overview, is going to be that there are so many more conditions that fall under these categories than what we will talk about even throughout your entirety of EMT school, even the entirety of paramedic school if that's your goal. Medicine is a deep topic. There's a reason that there are specialists, doctor specialists, right, in each different kind of discipline, right, when it comes to different systems. It's because there's a lot to know about these individual systems. We are known a little bit for being jacks of all trades, but masters of none. We got to be ready to deal with the fall patient, to the delivery of a child, to the heart attack, to the stroke. There's so many broad things that we deal with on a day-to-day. Comparatively, if I worked in like a ear, nose, and throat office as an ENT, I'm dealing with the ears, nose, and throat. That's my lane, right? So just keep that in mind. This is only a brief glimpse of what is actually out there and how in-depth these concepts can be. So for urologic emergencies, kidney stones is going to be a big one that we'll talk about medically. I would even include things like kidney failure, even kidney infections, right? But anything that's going to fall under our urologic system being the system that excretes urine or that waste product. For endocrine emergencies, most commonly caused by complications of diabetes mellitus. Now, that's not entirely wrong. It's not entirely true either. There were a lot of different endocrine emergencies. Endocrine is essentially just hormones. So if there's hormone imbalances, that's not always diabetes related. However, diabetes is definitely related to a hormone imbalance itself. So just keep that in mind, right? For the record, going back to neurologic as well, but endocrinologists, neurologists, some of the smartest people out on the planet here. I myself am not one, so we are going to be, of either, we are going to be having, once again, very brief glimpses into this. This topic gets so much deeper than you think. Hematologic emergencies, so blood, right? Blood problems. Now, kind of the general catch-all they're going to put here is maybe the result of sickle cell or blood clotting disorders, potentially, right? Now, there's, once again, lots of different conditions out there. Thing with bleeding, or excuse me, hematologic emergencies, is that they're not obvious, right? It's one of those things that you can't look at someone and be like, yep, that guy's a hemophiliac. We don't know. You're going to have to ask the questions. Just also understand, once again, hematology, deep topic. Even when you do the actual hematology chapter, that lecture is fairly short. There's only a few conditions we talk about. Once again, there are many, many out there. So keep that in mind, but you do need to ask the questions. For immunologic, right, so our immune system involves our body's response to foreign substances. The big one it's going to bring into this is going to be anaphylaxis. So down the road, you will talk all about that. Toxicologic, include poisonings and substance abuse, which you can kind of put that under an umbrella if you want. But yeah, it's going to be some sort of toxin entering the body system, and it's going to generate a result. Whether that result is something mild or systemic really depends on the substance and the dose. The dose makes the poison. Now, some medical emergencies can be caused by psychological or behavioral problems. Definitely something we run into. Psych is a very pretty wide spectrum of that as well, especially when it comes to your presentations and how people respond to those. And then lastly, but not to be forgotten, lastly on this list, gynecologic emergencies. So involving female reproductive organs, kind of a subset of that would still be obstetrics, OB, right? So obstetrics being childbirth, still going to be a female reproductive case. I wouldn't call that a problem necessarily. Depends on your viewpoint on it, I guess. Here's a big long table that if you want some kind of examples of each of these categories, it will give you a few. Now, with medical emergencies, it's not like trauma. Trauma, you walk up, someone's got 2 broken legs and they're looking 2 different directions instead of the straight line they're supposed to be in. Pretty obvious, right? Now, when we talk about medical, questions need to be asked. By asking good questions, you'll figure out what's going on. So by extension of that, kind of a little phrase I stole from a previous instructor I heard, good questions, getting a good history will solve your mystery, okay? Gotta ask questions. That's a huge portion of this because there's so many things we don't know. And if we think back to even as simple as signs and symptoms, signs we physically see, symptoms the patient is experiencing, but we can't really see it. With an example of a sign being like, vomiting. You can tell if someone's throwing up. It's hard to tell if someone has a headache, right, necessarily, or someone's feeling fatigued. Sometimes it's obvious, but that's usually a pretty extensive case on that. Anyway, moving into our assessment. So similar to the assessment for trauma, but with different focuses on, right? So the focus of the medical is going to be more so into the nature of illness, the symptoms, and the chief complaint. The chief complaint is what the patient is complaining of. It's the one reason, if they had to pick one out, that we showed up to see them. What can we help with? This is the big one, right? That would be the chief complaint. Now, like I said, we have to establish that accurate medical history. Big piece of it. Think about it just a little bit, right? If someone's had 3 heart attacks and I show up and I say, hey, what's going on? I'm having chest pain. Well, have you ever had anything like this before? Yeah, I've had 3 heart attacks. Well, I ask, does it feel the same? And they say, exactly the same. Well, it's not crazy for number 4 to be right around the corner, right? If it's happened once, it could happen again. That person's already got a predisposition for whatever that condition is. So by getting the history, it can help answer some questions for you. Now use dispatch information to guide your initial response. I'll come back to that. And then do not get locked into a preconceived idea of the patient's condition. I will come back to that. So dispatch information. It's great. It is one of those things that is going to kind of guide you about what is going on. What are we going to? Now, the reason I got to expand on this a little bit is because if you think about it, once again, these people are not physically there. They're on the phone talking to somebody who is either having a medical emergency or is near someone having a medical emergency. And at that point in time, tensions are high. Mistakes get made. Another thing is, once again, they're on the phone. If somebody is having difficulty breathing over the phone, or excuse me, rephrasing, somebody's having an anxiety attack and they're on the phone, it's going to sound like difficulty breathing, right? Well, it might be something as simple as anxiety attack. Might. I don't want to say everything is going to be anxiety, but there's a chance, right? They could be wrong. Dispatch notes are great, but can be unreliable from time to time. This is why you need to double check and get a good assessment in to figure out, okay, was dispatch right or wrong about this? Because it's not uncommon for things to show up and it's like, oh, this is actually the issue. An example of that, I was dispatched out to a fall patient, fell in her home. And then we showed up, she's like, yeah, I don't know, I kind of felt off and I fell down. And then sure enough, she was having a stroke. That's what caused her to fall, right? Well, that totally changes the demographic, or excuse me, the call from dispatch's perspective. This is no longer a fall. This is a stroke. We need to get going, right? So just keep that in mind. These dispatch information is great, but it can be a little misleading from time to time. Now, don't get locked into the preconceived idea. We call this tunnel visioning. It's very common, especially newer people, as you're kind of figuring it out and you haven't seen the world quite yet in this realm or in, with some experience, real world experience. It's not uncommon for them to lock into the initial complaint, right? Yeah, I'm just having a hard time catching my breath, says the patient. And I say, okay, well, then I start diving into all the lung questions. And I never ask, are you having any chest pain? Sure enough, they're having chest pain. And that's what's causing that discomfort. And they're having a hard time catching their breath because it's a heart issue with the lungs being affected as well, right? So be careful. You don't want to get too locked in. And depending on the topic, as we've gone through all the systems already, it can be easier said than done to get out of that tunnel out of that tunnel vision. Breathing problems can look like breathing problems. COPD and CHF might look like COVID or pneumonia. It really just depends, right? This is where you got to ask good questions and got to get a good history and be careful. Don't be scared to backtrack a little bit. If you got to repeat questions, repeat questions. Now, assessment may be difficult with uncooperative or hostile patients. It's true. That is a demographic that we will run into. Maybe demographic's not the right word, but that is a patient type that we will run into, especially if you consider things like stress that's building from whatever condition they're dealing with at this point in time. Okay, so just hold on to that. There are going to be people who frankly don't want you there. End of the day, maintain a professional, calm, non-judgmental demeanor. Everybody's got their problems. You don't have the right to be judging these people too hard for their problems because you've had problems yourself, more than likely, just maybe different. Okay? Refrain from labeling the patients. Big one that we see is, oh, this is a new frequent flyer. Or, yeah, this is a new frequent flyer. We're going to see them all the time. End of the day, they still have complaints, right? Frequent caller may have different complaints every time. You never know. As we are not in the business of saying no. If we get called, we show up and we help. That is what you're paid to do. That is what you are expected to do. Okay? So just because you see them frequently doesn't make them any less valid. It may be frustrating. I totally get that. It's 3 a.m. You've seen this person every day this week. It is what it is. You still got to go and check it out. Don't let your biases kind of get in the way of being a successful provider. Now for scene size up, remember, above all, your safety is the most important. It's hard to help others if you are sick, hurt, dying, bleeding, whatever yourself. End of the day, you are also just becoming another patient with more problems that we now have to get maybe other units in, which could be disrupting the service area that you work in, right? But scene safety, make certain the scene is safe. Standard precautions, when we say standard precautions, we're talking PPE, right? Personal protective equipment, your jazz hands. Put your gloves on. Masks is going to be a big one. I know masks are not a popular topic nowadays, but just remember, you are going into the field where you see sick pretty frequently, right? even to that point, not only are you seeing sick, it's not like a hospital where a sick person comes in, you're going into a sick person's home, okay? But there could be multiple sick people, or you could be going into like a homeless shelter or an unhoused shelter, however they want to phrase that now, right? But you can be going into a shelter where there's a bunch of sick people. Put your stuff on, keep yourself protected. The last thing you want to do is get sick more frequently. And also the last thing you really want to do is bring sickness home to your families, potentially children, right? Now, we also need to determine the number of patients. We want to make sure we have the right amount of equipment, personnel needed to handle this situation. I don't need a whole bunch of people if it's one sick lady, I'm making this up, but a lady who's been in her bed for a week, had pneumonia, versus if we get to a call where it's a bunch of difficulty breathing, maybe headaches, shortness of breath, maybe dizziness, and it turns out there's a family of 6 who had CO, carbon monoxide, circulating in their house. Well, I can't take all 6 of them in one ambulance. You're going to need more people. So just keep that in mind. Now, when it comes to kind of going back to your safety, I have a very specific order when it comes to that. Use it if you like. I tend to think it's pretty great, but the order of people we need to protect on scene is ourselves, our partner, our firefighters or police, depending on the type of system you work, but our other responders, the bystanders, and then last but not least, the patient. Now, the reason the patient's at the bottom of that list is they're already in a bad spot. We cannot afford to put more people in a similar position. Protect those around the patient so that we can take the best care of the patient possible. Now, once again, we are in medical, so we are talking about a nature of illness, right? What is causing this person to be sick? Which kind of brings the concept of index of suspicion, your awareness of potentially serious underlying injuries or illness. Your index of suspicion is kind of your spidey senses, right? What are you seeing that's making you nervous about this patient's condition, and what do we need to get involved in, right? This is also where you get to kind of play detective. They have a nature of illness, but you have an index of suspicion that this illness could be over something from this region or something from this region, right? Could be something GI, respiratory, I don't know, I'm making these things up, right? But it is one of those things. It's kind of your spidey senses of, okay, this is something that is underlying that I need to get involved with, because if I don't, things are going to get worse. So moving into our primary, right? So develop a general impression. Now I kind of have another kind of ism I like on this one, and I'll talk to you about it after here. But perform a rapid examination of the patient. We want to make sure that we're getting into kind of the meat and potatoes. Let's get into the ABCs, right? Which I believe those will come up. Yep. Let's start getting into the ABCs, but more so even before that, let's check for things like bleeding, right? Or any, what's their level of consciousness? Is there something where the patient can't talk to me because they're not lucid enough? Yeah, and then quickly determine their level of consciousness. Now, when it comes to general impression, I like to think of it in simpler terms: sick or not sick. When I walk into the room, does this person look sick or do they look okay? That's going to kind of change my speed a little bit, until obviously you get information where you might have to dive in a little quicker. But yeah, sick or not sick. And that same concept can still apply to things like trauma. I know we're talking medical overview, but they can apply to trauma. If I walk up to someone and they got a broken femur and their leg's making a hard right turn, well, yeah, I would call that sick. I need to get involved, right? Versus someone who fell down, they're maybe a little woozy, but they feel okay. Okay, that'd be a not sick. We have time to kind of hang out and get things figured out a little bit. So moving into our ABCs, airway and breathing. So in conscious patients, ensure the airway is open and that they are breathing adequately. Another term we can use for that is a patent or patent, however you want to pronounce it, but patent airway. Okay, patent just means open, it's working. Now, when we check for breathing, we are checking respiratory rate, depth, and quality. Okay, another way that we think about this, and how I will teach a lot of my students, is look into their breathing rate, rhythm, and quality. How fast are they breathing? Is it in a normal rhythm, in, out, or not? And then quality. Is it shallow? Is it deep? Okay, so you can kind of make adjustments from there. Because depending on what we're seeing, different responses can maybe give different ideas about what the underlying issue is. Now, consider applying oxygen if breathing has been affected. I will say for a lot of the NREMT stuff that if you fail to put oxygen on a patient during an assessment, it is a critical fail. Now, is that real life? Not always. But For where you're at, remember, the whole goal of where you're at right now is to get past the NREMT so that you can get a job, right? And then you can start kind of playing that game a little more, following your protocols. Now, for unconscious patients, make sure to open the airway using proper techniques. We are in medical, so we're more than likely going to do things like the head tilt chin lift. Jaw thrust is going to be more trauma with neck trauma or spinal trauma involved. Okay, but the head tilt chin lift, for adults, with kids, we might have to do some things different. Big one with pediatrics, making sure we pad under their shoulders to accommodate for that larger back of their head, right? Because if I got a big back of my head and I lay down, I'm going to do this, which is not necessarily an open airway. So by padding the shoulders, you bring them into that neutral, what they call a sniffing position, and it keeps everything lined up, okay? Now, apply oxygens to patients who are in shock, have difficulty breathing, or if there's low saturations measured. Now remember, our normal oxygen saturation is 94 to 99%, right? And remember, we get that through our SpO2, which can be a fairly unreliable vital sign. There's a lot of circumstances that can affect the SpO2 that makes it inaccurate, right? So for example, cold fingers, fingernail polish, dirty hands, even light can be another one. If there's too much light that washes the laser out of the SpO2, you'll get an inaccurate reading. So gauge your patient as well, right? But these are going to be instances that we want to put oxygen on our patients, especially shock. Now, unconscious patients may need airway adjuncts and ventilatory assistance with the BVM. The airway adjuncts, the two big ones you'll need at the EMT basic level, is going to be your OPA, or the oropharyngeal adjunct, and the NPA, your nasopharyngeal adjunct. One goes in the mouth, one goes in the nose. I'll let you put the math together there. Okay, but those are going to be the adjuncts you'll need to use. Now, when it comes to ventilatory assistance with a BVM, typically we will use a BVM for people who are apneic. Now, apneic being there's no breathing, right? But there are caveats to that. Now, the NREMT right now is kind of pushing anybody breathing less than 8 times a minute, we need to assist their ventilation. So what you'll do, they're, I don't know, maybe conscious, if they are conscious for sure, 8 times a minute breathing, make sure you're coaching them, right? Put yourself in their shoes. If you're having a hard time breathing and someone says, I'm going to put this on your face real quick, you're probably going to say, no, thank you, right? But it is one of those things, if you coach them and tell them what we are doing and why we are doing it, they're going to be okay. So with 8 breaths per minute, you're going to get a good seal on their face after explaining to the patient what you will be doing. And as they take a breath in, you're going to just give a little puff on that BVM. Give them just enough air to finish that breath. Then slowly, over the next 5 to 10 breaths, you will adjust that rate until you're delivering 1 breath every 5 to 6 seconds in adults. Okay, kids is gonna be a little bit different. When it comes to, there's another caveat with BVMs that is kind of on the fence with some things right now. Anybody who's breathing over 28 times a minute also needs a BVM. I'd say depending on the circumstance. Okay, if it's going to be something where it's like an anxiety response where they're breathing really, really fast, maybe we can try coaching them down first. Okay, if we can't coach them down, yeah, maybe we move to our BVM, and we're going to do a similar thing, but we're going to try and slow them down, right? We're going to match a breath and then give them 1 breath every 5 to 6 seconds over the next 5 to 10. Now for circulation, in a conscious patient, check the radial pulse and observe the patient's skin, color, temperature, and condition. So skin is one of those things that gives you a lot of information very, very quickly. We can observe it. We can make kind of estimates or judgments on what's going on based on looking at people, right? So skin color, temperature, condition. When we say color, we're talking about pale. We're not talking about, as one of the things. We're not talking about skin, like melanin content, right? We're not talking about different colored skin necessarily. We're talking about if their skin is pale, or are they red, or are they blue, or are they a yellow color, right? That's gonna help us get some information. Temperature, are they hot, cold, febrile, not febrile? And then condition, are they really dry? Are they really sweaty or diaphoretic, right? Those can help guide our answers as well. And then for unconscious patients, assess circulation at the carotid artery. Now this is a big one, and I am a little bit of a stickler with this. Radial pulses are great. You will find them on most of your patients. I'd probably venture to say somewhere between 75% to 80% of your patients, you will be able to get a radial pulse on, depending on your system. For the carotid artery, however, that's going to be more important in unconscious, unresponsive patients. Reason being is at certain points we lose the ability to feel a pulse depending on their blood pressure. So for example, with our radial pulse, the radial pulse is no longer palpable, or you can't feel it, if the person is about 90 systolic. If you do feel it, it's going to be difficult, right? Anything less than that, you're not going to be able to feel a radial pulse. Well, people can still be alive with a blood pressure of 80. I'm not saying they're thriving, but they're alive, right? That's where we would maybe look into the carotid artery. The carotid artery and the femoral artery, your central pulses, will be the last ones you'll lose because they supply the important structures, right? Most of your abdomen and your chest, as well as your brain and your head, right? So we tend to lose our carotid pulse around 60 systolic. We tend to lose the femoral around 70. Those numbers may differ depending on what you've heard, where you learned, so on and so forth. But those are the numbers I was trained on. 60 for the carotid, 70 for the femoral. So just keep that in mind, right? We can still have a palpable pulse at a low pressure, but we can also lose pulses depending on how low their pressure is, depending on which ones we're trying to feel for. Okay, so feel the carotid, especially if we think like cardiac arrest circumstances. If you go in and you think someone's in cardiac arrest and you check a radial and they have a blood pressure of 80, and you can't feel it, and you start doing chest compressions, they're gonna be pretty pissed when they wake up and they're like, why does my chest hurt so bad? Central pulses, very, very important. Now, transport decision. How fast do you want to get there? Do we have time to stay and play on scene, or do we need to load and get going? Okay, load and go, stay and play. Now, patients in need of rapid transport. So some examples: unconscious, altered mental status, airway breathing problems, and then obvious circulation problems such as severe bleeding or signs of shock. Remember, shock is not always hypovolemic in the sense of trauma, right? So keep that in mind. But yes, these are some examples. Now, this is a very small list for examples. A lot of it will be clinical judgment depending on what you're seeing with your patient in front of you, okay? But yeah, you got to make the choice. This is where sick or not sick starts to play in. They look sick, we should probably get going after doing all of our primary, right? But if they're not sick, maybe we have time to ask more questions, hang out on scene, gather more information. It really depends on the circumstance. So history, like I mentioned, very, very important. We are in medical. This has to be done. You need to ask a good question set. Sample, OPQRST, those are great. Those are fantastic little mnemonics to help you remember. They are only a small piece of the puzzle. Remember, the better you understand a topic, the better your questions will be, okay? You can ask more in-depth questions that might actually unveil some information to you. This is the kind of thing that requires you to do some work outside of school, outside of work. Study, learn, right? Because we want to be great providers, not good providers, great providers. And great providers can think around a situation and ask thorough enough questions outside of the basic ones, sample, OPQRST, to find the answer and at least get a better treatment. And honestly, half the time, what you're finding is stuff we can't really treat. Remember the end goal, the big picture. We need to set our patient up for a successful and a good outcome, and the more information we give the doctor, the better care they can provide. Okay? So gather a thorough history. So determine what the problem is, what's causing the problem, gather a history. And then for unconscious patients, survey the scene for medication containers or medical devices. Another thing we can utilize, yes, containers and devices, if you see them, it's great. Right? Maybe give you some information. But remember, we also have resources. If there's other people around that see what's going on, talk to them. Now, you might get differing stories if you ask lots of different people, but end of the day, more information is still information. The only downside is now you have more you need to cipher through and decide what's garbage and what's not, okay? But definitely do your due diligence, ask the people around. So obtain a sample history, use OPQRST, right? So your mnemonics, so sample, signs and symptoms, allergies, medications, pertinent medical history, last oral intake, and events leading up. Now, some confusing ones, that are not confusing, I guess, but confusion I've gotten from my own students. Events leading up. Now, a lot of these will double dip into OPQRST, and you'll see why here in a moment. So just keep that in mind. Hold on to that one for a second. But P, pertinent medical history. Is there something that you have in your medical history that pertains to what's happening right now? Okay, this is something you'll run into, in my experience, it's been a lot of older folks of, hey, What kind of medical history do you have? I'm having, kind of give you more picture, I guess. I'm having chest pain. Okay, what kind of medical history do you have? Well, I had my appendix out when I was 9. Neat. Not applicable, right? When we say pertinent, what is something that you got going on? We want to know everything if there is a lot, but what of that list is going to be something that could be affecting the person now? Now, OPQRST, onset, provocation, quality, radiation, or region, depending on which one you prefer, severity, and time. Now, the one with this guy, so onset, what were you doing when this started? Well, that kind of lines up with events leading up, so you can double dip. And it's okay to ask twice. Just verify, right? You already kind of know the answer, but maybe it'll change. Or you already know the answer, and so that might give you the chance to think into your next question while they're giving you the same answer you're aware of. Now, the O is onset. What were you doing when this started? The T is time. When did this start? I tend to see these flip-flopped. Okay, it happens from time to time. When did this start? PQRS. Oh, I'm on the T. Just confirming when this started X amount of minutes ago or hours ago or whatever, right? We want to make sure it's differing. Okay, that's kind of the advantage you have by asking both of these, is that they double dip enough where you will get your answer. You just got to ask the right questions. Okay. Record any allergies, conditions, and meds they take. Be aware some patients will take numerous medications. Okay. Now take the meds with you to the hospital. Not entirely on that, and I'll come back to that. But yeah, some patients will take numerous different meds. Okay, to the point where they see multiple doctors, and these doctors aren't talking to each other every day. They're not, oh, I have so and so. I have Becky Smith coming in today. And I talked to her neurologist, I talked to her cardiologist, I talked to her primary care physician. They don't do that. So they can all prescribe things, and sometimes they miss stuff. And it happens where the patients will end up taking meds that shouldn't be mixed, or they'll get double, triple dosings of things that they shouldn't. It happens, okay? We still gotta ask the questions. Now, when it comes to taking the meds with you to the hospital, I'd say I let your system decide that, your protocols decide that. I never really did. Reason being is that the hospital has all of the meds they're gonna need to take for the most part, unless it's something really rare or weird, right? To the point where that they need a dose, you can tell the hospital and they'll give them a dose, okay? So it just depends. I would leave that one up to your protocols and your local agency. Now, our secondary, when we talk about trauma, the secondary is gonna be our hands-on. Let's palpate, let's see if we can find stuff that we missed just by using our eyes. Okay, now medical is a little different. There could be some hands-on, and I'll give you some examples of that here in a bit. But just keep that in mind. It's not gonna be the same as trauma. We're dealing with two separate beasts here. So may occur on scene or en route to the emergency department. In some cases, you may not have time. Yeah, if you have an ABC problem on a really sick patient and you are transporting lights, sirens, all the things, and you have a 5-minute transport, you may not get to this. End of the day, we want to, because we can get better information, right? Or give better care at that point, and maybe provide the doctors and nurses with more information, but just keep that in mind. You might not have the time. Now, the physical exam. All conscious patients should undergo a limited or detailed physical exam. I would make this very dependent on the complaint, right? If it's, say, like a psych patient, psych person's having an issue, well, there's nothing to really palpate unless they hurt themselves, right? There's nothing to really palpate. Same thing with diabetes. I'm a diabetic, I got a low blood sugar. Did you hurt yourself? No. There's not a lot of reason to get hands-on. Now, there are certain times, like a good example would be chest pain, or abdominal pain even, but chest pain, right? I'm having this crushing chest pain. Well, if I push on your chest, does that pain go away or get worse? And they say, oh, when you push, that pain gets really, really bad. Well, at that point, that gives you information. I'm not thinking this is a heart problem anymore. I'm thinking this is a chest wall problem, right? I'm not touching your heart. I'm not physically manipulating your heart. I'm leaning in towards the chest, or the rib pain. Inversely, right? I'm having chest pain, I palpate. Is that pain getting better or worse? Oh no, the pain's pretty consistent. Okay, I don't think it's a chest problem now. I think this might be a heart problem. You can give yourself some information. You can rule some stuff out, find some pertinent negatives, right? I know it's not chest wall pain, so it kind of redirects my focus. This is where that tunnel vision can start to show up. Or abdominal pain, right? Having abdominal pain right here, right upper quadrant. Okay, let's palpate. Does it get better or worse when I palpate? Oh, it gets way worse. Okay, maybe this is a liver issue, right? When it comes to the abdomen, make sure you know kind of the general region of the organs. Now, for unconscious patients, always perform a secondary assessment of the entire body or head to toe exam. Yes, when they're unconscious, things start to change. We don't know what's going on and they can't tell us. So let's just do a quick head to toe assessment. Let's make sure we're not missing anything that might indicate, oh, this is trauma. We show up as an unconscious person. Well, on my secondary real quick, I notice he's got a big old cut on the back of his head. Well, maybe this was trauma induced, right? Inversely, we show up, unconscious patient, quick secondary assessment, do the head to toe. I find nothing. Oh, maybe this is gonna be something vital sign related, right? Then we can rule out physical problem at that point. So for the physical exam, examine head, scalp, face, examine the neck, chest, abdomen, arms, legs, and their back, okay? I have a little mnemonic I like for this one. It's really not a mnemonic, but the first one is HEENT, H-E-E-N-T, stands for head, ears, eyes, nose, throat, and part of the head is gonna be scalp. Right from there, we can move to the back of the neck, right? Because the T is throat, so I'm looking at the front already. Back of the neck, chest, abdomen, pelvis, legs, arms, back. Okay, so just keep that in mind. There's different ways to go about it. That's something that if you're given the opportunity to write something down for your patient assessment kind of checkoffs, it can go a long way just to write those body systems down real quick. It's just a catch-all, just in case you miss something, it's a good place to fall back to. And then vital signs. So pulse, rate, quality, regularity. Simplified, you can do rate, rhythm, quality again. How fast or slow is it? Is it regular or irregular? Is it a normal cadence or not? And then quality, is it thready or weak? I can barely feel it. Or is it bounding? It's really, really strong to the point I think they have high blood pressure. Or is it normal, right? But rate, rhythm, quality applies to breathing and pulse, okay? Now, if you think about it also, when it comes to vitals, you can break it down again even to another kind of way of thinking about it and organize your thoughts, is that if we need to find the rate, rhythm, quality of pulse and rate, rhythm, quality of respirations, there's other things we want to know around that as well, right? Well, if we think rate, rhythm, quality of pulse, I want to associate my blood pressure. I know there's two when it comes to circulation, pulse, blood pressure. When it comes to my respiratory, rate, rhythm, quality of my breaths, what's their oxygenation? There's more information we can get on just the rate, rhythm, quality stuff. So keep that in mind. And if it helps you, lump them together. It'll help you remember, okay, there's two I need for circulation, there's two I need for breathing, okay? Get your blood pressure, and then consider obtaining blood glucose and pulse ox. Yeah. Now blood glucose, I would maybe, because I already mentioned putting pulse ox with your respirations, okay? But I'd maybe include things like temperature there, right? Temperature can be guiding. People are sick, they tend to have fevers, right? Well, that's important, that's pertinent if we're talking medical, so keep that in mind. For reassessment, so performed once the assessment and treatment have been completed, okay? So you'll be doing this pretty frequently, and begins and continues throughout transport. This is also where you can consider the need for ALS. If you are in a system where you are a dual EMT basic ambulance or car or whatever you want to call it, rig, truck, anyway, you might need to get ALS involved, right? Just depending on your system. Let's get a paramedic here. Maybe their whiz-bang paramedic stuff can help us with what we're finding. Reassess your interventions. Interventions is what did we do? Did we give meds? Did we give oxygen? Did we splint something? Did we do whatever, right? Let's make sure it's still working. If we did something, we want to make sure that something works until they get to a hospital. And then document any changes. Remember, in the eyes of the law, if you don't write it down, it never happened. So write thorough, encompassing charts. Okay, so for reassessment, frequency. If it is an unstable or critical patient, we need to reassess them every 5 minutes. If it's going to be a stable or non-critical patient, it's going to be every 15. If you're old like me and you've done this before, you probably heard different numbers. That's the new standard, 5, 15. 5 for unstable, 15 for stable. Now, when it comes to what the reassessment is, what are we looking for? What are we doing? One are interventions, as we were talking about, but two, you're basically doing an ABC vital check every 5 or 15 minutes as needed. You're reevaluating ABC. Because if ABC start to go downhill, they start to develop a case of deadness, and that doesn't look good for you and what you're doing or trying to accomplish with this person. So management, transport, and destination. Now, most medical emergencies require a level of treatment beyond that available in pre-hospital. Remember, our job is to get them to the right facility with the right doctors to give them a good outcome. Now, may require advanced testing available in a hospital, things like imaging, blood work, right? We don't have the capability out there. Maybe beyond the scope of the EMT to administer the meds, right? There's certain meds that even at the paramedic scope, they're like, nope, cannot give those. Those need to be monitored in hospital, okay? It is what it is. For locally here, I don't know every system, but insulin would be a good example of that. This person's got a really high blood sugar, we need to bring that down. I don't have insulin, that's a doctor's only, right? Or a prescription, depending on the patient. And then EMTs can use an AED, right? Remember, when in doubt, you can always use an AED. You can run a cardiac arrest. Now, something that kind of gave me a little bit of, I don't know if confidence is the right word, but reassurance, I'll go with that. Reassurance when I was out in the field was that realistically, if I know what I'm doing in a cardiac arrest or a code situation, and I know how to run a code, and I know how to run a code effectively, and I can recognize this. That is the worst case scenario of every single patient that I will ever run. Every single patient that I ever run, the worst thing that can happen to them is they go into cardiac arrest. They die, right? Just bluntly putting it, they die. Their rhythms change. They're in a VTAC, VFib maybe at this point, right? Cardiac arrest rhythms. Well, I know what I gotta do here. It becomes an algorithm at this point. Okay, so keep that in mind. It does provide a little bit of solace with this whole thing. If you know you can run a code or handle a code, and that's the worst that's gonna happen, you can deal with a lot of things in front of you, okay? So scene time, maybe longer for medical patients than for trauma, yeah. Sometimes we gotta get stuff on board pretty quick, like albuterol for an asthmatic. If we're sitting in the middle of a park and they can't breathe, let's get this going. Right? Or maybe if we have time, let's start looking through their house. Let's look through their medication list. This is the time to be nosy. And if you're anything like me, you love to be nosy because the more nosy you are, the more information you find, the better you can help this person. Now, gather as much information as possible to give to the ED. Yep, the more information you have, the better treatment they can give. And then remember, if anyone's critical ever, we need to start rapid transport. We cannot fix these people necessarily in the field. This is one of the things that I don't feel bad about anymore, honestly. I have to kill some hero complexes. We're gonna fix everything, we're gonna be heroes, we're gonna save lives. Sometimes, sure, I can't deny that sometimes. Realistically though, your job is not to save lives. Your job is to be a good Band-Aid to get them to the person who can save their life. They need a hospital. There's not much we can do with some stuff, okay? Just keep that in mind. Now, type of transport, so for life-threatening conditions, you're gonna go lights and sirens, right? So everyone knows you're going. A lot of departments will often have some sort of opticom on their ambulance or apparatus, whatever it's gonna be that they're driving, that they can change the lights, the street lights as well, okay? So this is typically where you get people out of your way, right? Versus non-life-threatening, maybe it's a non-emergent transport. Yeah. You know, Mima's not feeling well. She's had a cold for the last few weeks. Just doesn't feel great, but she's not unstable. She's stable as she can be. Maybe we take a nice, easy ride, keep the intensity low, keep her comfortable, okay? Depending on your system, you may even turn Opticom on for that. Let's just transport them and change the lights. Depends. It really depends on your system. Now, modes of transport ultimately come in one of two categories, either ground or air. Okay, so kind of moving into it, ground transport EMS, usually staffed by EMTs and paramedics. This is gonna be your pretty standard ambulance you see on the road, with this one in this picture here being a very fancy one. But yeah, your ground ambulance, right? It's gonna be your typical day-to-day 911 or interfacility, depending on where you're going or what you're working with. Versus flight, air transport, generally staffed by critical care transport professionals and paramedics. There is an expectation of critical care if you're gonna do flight. You need to be able to handle real bad stuff because now you're not just 20 minutes from a hospital, you could be 3 to 4 hours from a hospital. Now you have to manage this person for a while, okay? And when it comes to the professionals, you can either have flight paramedics or even flight nurses, sometimes doctors and PAs, physician assistants, they'll hop on as well. Just depends on their training and what they're comfortable doing. But more frequently, at least here in this local area, is gonna be some variation of paramedic and nurse. They have different strengths, right? And that's why they keep that kind of diversity of scope on the helicopter, or the rotor as they call it, or fixed wing, which is a plane. They like to keep that generally different because nurses are better at managing things like drip lines and medication counts at that point. Paramedics are better with airway things for the most part, not general. That's generalizing, right? Not necessarily all encompassing, but that tends to be where they have their best abilities, right? We want to make sure that whoever we put on this type of apparatus is the best at what they can do in their own scope, and then by putting them together, making it a well-rounded and efficient team. Now, when it comes to destination selection, generally closest hospital should be your best choice, right? That should be the destination of choice. Depending on where you work, it can be up to the patient, right? Especially if they're stable, they get the choice on which hospital if you're in an area where they have multiple, okay? Sometimes it's not, right? Sorry, we have to go to a trauma center. Sorry, we have to go to a burn center. Sorry, we have to deal with whatever, right? If there's a specific unit or hospital that handles one type of complaint very, very well, it's likely you're going there for an unstable person. Okay, now sometimes the patient will benefit from going to another hospital capable of handling their particular condition, kind of like I just said there. Now, another thing that a lot of people didn't know, and I wasn't aware of this before I got in the field, is that there are standalone emergency rooms. Now, we're in an area where there's more rural spots around us, where they don't have a big full-blown hospital. They do have an emergency room for emergencies, right? Now, this is where you have to make choices. Because just because they're an emergency room doesn't mean they can handle what's coming in, but they might not be able to handle the long care. If you bring a sick person to a standalone ER and you get there and they are septic, they need antibiotics and they need to be monitored, they need to be in the ICU, well, they don't have one. So you're going to be taking somebody from that ER to a different hospital, okay? This should be something you at least consider depending on where you work. What I would recommend, know your area, know which hospitals are available, know what your destination options are, okay? And then there are certain things, like here locally we have a victim center for typically things like domestic violence, sexual abuse, things like that, or sexual assault. And that's here locally, it's a facility ran by nurses. It's locked from the outside. You have to make phone calls. They will let you in, and they typically will just handle the sexual assault cases like that, but a more specialized, right? It's specific to the complaint. For infectious diseases, so general assessment principles, right? Approach them like any other medical patient, right? I would say if you know that they have some sort of infectious disease, put your PPE on, right? Scene size up, standard precautions, primary assessment, nothing's really changing. Get your history, OPQRST, elaborate on the complaint. Nothing's changing so far, right? Sample, baseline vitals, it's all the same, right? If you're not catching on already, you got to keep it consistent for the most part. Where things start to change is when we get more information that might enlighten us about what's actually happening. Ask whether the patient's recently traveled or come into contact with someone who's recently traveled. Different areas of the world will have different illnesses, right? The likelihood of me catching dengue fever in Idaho is not super high. Me catching dengue fever down in South America, potential, right? So just things to consider there. So focus on any life-threatening conditions identified in the primary assessment. Remember, be empathetic. These people are potentially having the worst day of their life. You don't want to make this day worse. Because honestly, transparently, the thing that people remember is not so much what we did all this cool medicine or cool EMT things. They remember how we treated them, right? As people, not medically. So be empathetic, right? Be dignifying. Now, place the patient in a position of comfort on the stretcher, keep them warm. Standard precautions once again. Now, epidemic versus pandemic. Obviously, a few years ago now, 2020, we had the COVID pandemic kick off. So let's talk about some differences. So epidemic versus pandemic. Epidemic, new cases of a disease in a human population substantially exceeding what is expected. Yeah, there's more people in this city or this state that have this illness that we were not prepared for. Inversely, pandemic, disease outbreak that occurs on a global scale, COVID, right? That affected everywhere. That was not just a US problem, not just a Europe problem, not just a Asia problem, it was everybody, okay? So keep that in mind, and depending on which one we're dealing with will kind of be dictated by or excuse me, what you'll be doing with it will be dictated by your agency and your protocols. So some different types of diseases that you may run into. So those with chronic medical conditions, or going back, the flu, right? But those with chronic medical conditions, compromised immune systems, and the very young and very old are susceptible to complications of the flu, meaning that this has the likelihood to progress into something different, like pneumonia, okay? Transmitted by direct contact with nasal secretions and aerosolized droplets from coughing, sneezing by infected people. Yeah, right, I'm pretty sure the flu is not news to anybody who's trying to get into this field, and likely they've had something like a flu shot once upon a time, or not at all, I don't know, live your life. But just keep that in mind, you will be seeing a lot of these people, right? Aerosolized droplets is something we do quite a bit. You're dealing with them coughing. It's okay to put a mask on your patient as well. If they're coughing and they're not covering their mouth, put a mask on them, right? Worst case scenario is that, yeah, sure, some of it goes through, I guess, but if you have a mask on, they have a mask on, the likelihood of it being you getting sick is very low. Now, for diseases that can be passed by respiratory routes, right? So always wear your PPE, so gloves, eye protection, HEPA respirator or N95, and then surgical mask on your patient, like I said. And then annual influenza immunization is important for EMS personnel to protect providers and patients. Some departments may offer this as part of just the cold and flu season, usually kicking in around late September, October, okay? I'll leave it up to you. I know that immunizations and vaccines are also not a very popular topic right now, but they can help. And I understand why some people would have their reservations. It does make sense. Just keep that in mind that you're going to be, or keep in mind that you're going to be seeing sick people in their natural habitat, okay? And if you're around sick people in their habitat, you have a chance of getting sick, okay? So do what you want to do to protect yourself. But remember, end of the day, it's all about going home healthy, happy, and keeping your family healthy and happy. Safe too, I guess we can throw that in there. Herpes simplex, so common virus carried by humans. Symptomatic infection caused by vesicles, kind of like sores is another way of thinking that, like kind of openings, that appear on the lips or genitalia, depending on which type they have, and then can cause more serious illnesses in susceptible patients. Another thing too is that anytime we have an open wound, right, if a sore is an open wound, the concept of infection or infection can also start to show up, okay? Now the primary mode of infection is going to be through close personal contact. In my experience, well, actually, I'll hold on, I'll tell that after this. So, HIV. So EMTs face risks of exposure. You're going to be around HIV. You're going to be around people who have blood disorders like this. There's no vaccine for HIV. With the progression of HIV turning into AIDS, can still be fatal. However, with treatment, patients can expect a near normal lifespan. So essentially what this is, HIV and AIDS, they're not the disease that kills you, okay? What they do is they weaken your immune system to basically nothing. So the next illness, I don't know, the flu that you get will be the thing that kind of makes you kick the rock, right? Kick the bucket. But not easily transmitted in the work setting. Your risk of infection is limited to exposure to an infected patient's blood or bodily fluids. Now, this is where I was going with it. In my experience, people who have bleeding or disorders like this that are transferred through blood, disorder is not the right word, sicknesses or illnesses like this that transfer through blood, they don't tend to tell you they have them until there's already blood on your gloves, okay? So just be cognizant, wear your PPE. It's there to protect you. Your skin is a great barrier. If you get blood on some just, intact skin, you're likely not going to get sick. But if you have any sort of opening, any sort of wound, there's potential. So wear your stuff. And also, maybe don't let people who have blood all over their hands start touching you, right? Just things to consider. Now, patients with HIV, or many patients with HIV, show no symptoms. So wear your PPE. Make sure when you're disposing of your needles, you're putting them where they need to go, a red sharps container, biohazard container, and then cover up any open wounds, right? On top of just stopping bleeding, which has already been kind of covered in our circulation side. And if you think a patient's blood or secretions may have entered your system, you need to seek medical advice as well as tell your infectious disease officer. You need to report it, okay? Hey, I think I got blood in my cut and this person has whatever, HIV or maybe like hepatitis, right? You gotta say something because now you're at risk of getting sick yourself and you need to be under evaluation for that. And they're gonna likely do lots of tests and make sure. but you gotta say something. Communication is huge, just generally in life, but especially in this field. If you're not talking and they don't know it's a problem, they're not gonna help you. If you want help with something, you gotta say something. No one is just gonna show up and be the hero for you, especially if you're supposedly the hero, right? Okay, moving on, hepatitis. So itis, inflammation, hepato being liver. So hepatitis mashed together, we got inflammation of the liver. And now usually there's gonna be some sort of infection associated with that as well. Can be caused by either viruses or toxins. Now there are different types of hepatitis that are spread different ways, okay? And now there's no way to tell which hepatitis patients are contagious or not, because once again, they're gonna say I have hepatitis. We're gonna have to figure it out. There is a vaccine for Hep B, and that is one that is pretty heavily recommended for EMTs because Hep B is spread through blood. And once again, they don't tend to tell you they have these kind of diseases until the blood is already out and about and potentially on you. So here's a list of all the different hepatitis you can see and how they're spread, right? So Hep B, Hep A, fecal, oral, infected food or drink. Hep B, blood, sexual contact, saliva, urine, breast milk. Hep C, blood, sexual contact, and then Hep D, blood, sexual contact. If you're noticing a trend, yeah, wear your PPE. Meningitis, so the meninges are the layers that surround your brain and your spinal cord, okay? Itis, inflammation, so we're talking inflammation of these linings. Now, inflammation of the meningeal coverings of the brain and spinal cord, with most forms of meningitis not being contagious. There are some that are, and trust me when I say you do not want meningitis, okay? It is a life threat at a certain point. Now, standard precautions, once again, wear your mask. If you're worried about the patient having it, make them wear a mask. Can be treated in the ED with antibiotics. And after treating a meningitis patient, contact your employer health representative. They're gonna wanna know. Make sure you're reporting or at least talk to the doctors and maybe talk to a supervisor and see who should we be talking to. I wanna report a meningitis case, okay? And then kind of for the record, anytime you're putting a mask on a patient, if you run into well, I can't breathe if I have the mask on. You can always throw a nasal cannula on and then put the mask over the top. That way you can ensure that they're breathing 100% oxygen if they decide to fight you on it. TB, tuberculosis, this is one you will definitely be tested for before getting into the field, but most infected patients are well most of the time. Tuberculosis is one of those diseases that can hides in your spinal canal. Now, chronic mycobacterial disease that usually strikes the lungs, with patients who pose the highest risk almost always having a cough. N95 or HEPA mask is required to stop that droplet. You don't want tuberculosis, especially if you're exposed. Once again, it can pop up anytime once you have it in your system. But fun fact, at one point in time, tuberculosis killed like 30% of the world's population under the age of 30, right? That's a pretty big number. It's something that definitely you can get caught being sick with. Which also, prior to COVID, this was the only complaint that the agency I work for required us to put an N95 on. Okay, well, a lot of us don't know it's gonna be something that we need a mask for until we're already there, right? Until you're breathing that person's air. This is where reading the call notes and maybe just keeping the mask in your pocket. I was very frequently caught doing that. I'd keep a mask or two in my pocket. On the off chance this person turns out to be sicker than I thought, I have it, I can throw it on, and then at least take some precaution. It's not gonna be perfect, sure, but it's something, I'm trying, right? And that's all that matters in that until you get sick, and then that's a whole different ballgame. But putting the effort forth to protect yourself is always, always, always gonna be worth it. Now, absolute protection from the tubercle bacillus does not exist, with 1/3 of the population being infected with tuberculosis already. Okay, now, you will have a tuberculin skin test for this. You'll get them fairly regularly, with preventative therapy being almost 100% effective. Prevent from getting it in the first place, and they're good at it, as we're seeing, right? Protect yourselves. But what this test is, they'll put a little needle subcutaneously, so just under the skin, not in the muscle, but under the skin, different angle of injection. And they'll leave a little red dot that's like the testing fluid. It'll leave a little red spot on your arm. You'll come back in 48 hours. They'll double check that spot. If it's gotten bigger, changed, warped, they'll let you know. And that's usually a sign of tuberculosis. If it's not changing, you likely don't have it. Congratulations. Whooping cough. whooping cough, right? Also called pertussis. Mostly affects children younger than 6. It's known as whooping cough because of the whoop sound that they make, but includes fever. And so when they have a big cough attack, cough, 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 when they get their first big breath in, it sounds like a sound because they're cough, 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 whooping cough, right? They're whooping at the end of it. Now, the best way to prevent exposure is to be vaccinated and then place a mask on your patient as well as yourself if you're worried about it. If you have kids, I don't want to stress this, or I can't stress this enough. If you have family, and especially young children, and you're a home and you're a provider and you're seeing things like this, these are the things you'll bring back and give to your children if you're not careful. Wear your PPE. It is so worth it. You don't want to give your kid whooping cough. You don't want to give your kid croup, epiglottitis, whatever. Those are things you will run into and you will see, and you do have the risk of potentially spreading it. So protect your family, okay? Wear your stuff. MRSA, so methicillin-resistant Staphylococcus aureus. MRSA, bacterium that causes infections. So you do have Staphylococcus bacteria living on your skin. It's a normal thing. I'm sure most people have heard of a staph infection before. MRSA is just a staph infection, but now it's got an extra little twist to it. It's resistant to a lot of antibiotics, so it's harder to get rid of. Now, in healthcare settings, MRSA is transmitted from patient to patient by healthcare providers' unwashed hands. You will be washing your hands very frequently. Get in the habit early. And when I say frequently, like I wouldn't be shocked to say I wash my hands 10 to 20 times a day on shift. Okay, which also, side note, get some good hand lotion because your hands will definitely get super dry and start cracking if you're not careful. And that's also the risk you run with using hand sanitizer a lot, is it dries your skin out. Now, factors that can increase the risk for MRSA: antibiotic therapy, prolonged hospital stays, ICU stays or burn unit stays, and then exposure to an infected patient. Right? If you're going to the places where sick people live, that's where the sick people diseases and bacteria are. Now, typically MRSA results in soft tissue infections, your skin being soft tissue, and it can be pretty gnarly. Remember, anytime we have an infection, it has the potential, if it goes untreated, to progress into sepsis. Patient can go into septic shock. COVID-19, I'm sure a lot of people have some variation of memory of COVID, but originated in Wuhan, Hubei province, China, quickly spread, infecting millions, killing hundreds of thousands. Now, the nice thing, quote unquote nice, is that it was not as life-threatening as they were planning it to be. Like for the original projections, it was like 1 in 7 people are gonna die of this, right? So that's terrifying. So the world kind of obviously upended itself. So for controlling the virus, social distancing and masks not on there, with symptoms including fever, cough, shortness of breath that appear 2 to 14 days after exposure. With the CDC website if you want more information on COVID. Yes, COVID was very real. That's when I actually started in the field, was early 2020. I watched a lot of people die of COVID. Okay. Now, was that going to be the end all be all? That's what caused it? I don't know. It's not for me to decide. But I can tell you that I saw people with COVID that didn't make it, right? Keep this in mind. This has progressed a little bit to a point where now this is a very manageable thing. It's basically another cold and flu type view. Obviously, there's different strains coming out. Well, it's been a while, but for a while, it was different strains every other month, it felt like. But just keep this in mind. Very real, is very spreadable. You don't want it, okay, depending on the variation you get. Some people had it harder than others. But just protect yourselves, once again. Now, MERS-CoV, Middle East Respiratory Syndrome coronavirus, first human case discovered in 2012 in Saudi Arabia, with no cure or vaccines at this present moment. This is going to be another one, if you suspect it, surgical mask on your patient as well as yourself. And then Ebola, 2014 outbreak of Ebola in West Africa. So incubation, meaning it lived in your body and kind of grew and spread for 6 to 12 days after exposure, with symptoms not appearing for as long as 21 days after infection. Okay, and then fatality rate for Ebola can be as high as 70% if treatment in an ICU is not initially prompted. Pretty life-threatening. This is one of those things too that a lot of agencies will have a, like, I don't want to say like pandemic response, but like that kind of infectious disease response personnel. Make sure they know, because they're going to have very specific plans for what to do with your apparatus, your equipment, yourself, your patient, if you run into it. Ebola is a big one. It's a painful death. and it's a terrifying one as well. So don't want it, wear your masks. Now the likelihood of it showing up, at least on our side of the world, I won't say is super high, but not impossible, okay? So for travel medicine, be aware of travel-acquired infections when assessing a patient who is recently outside the US. Yeah, gotta ask the questions. Were you out of the country? Yeah, where were you? I don't know, wherever they want to be, right? In the Philippines, making it up, I don't know. And they caught some sort of illness or disease over there that we don't have here. Well, we're not prepared for that necessarily all the time, so you might have some variety in symptoms. Okay, and when you encounter an ill patient with recent travel history, put a mask on them, get as much info as possible, 100% so that we can give information to the doctors and nurses so the hospital can give them the best treatment possible. Now, important questions to ask for travel-related stuff. Where did you travel? Did you receive any vaccines before your trip? Right, might give you a clue as like what they're looking out for. Were you exposed to any diseases? Is there anyone else in the travel party who got sick or is sick? Type of foods did you eat? Different parasites live in different parts of the world, different foods. And what was your drinking water? Similar reasons, okay, as the food. So, in conclusion, assessment and treatment of medical patients can be challenging and interesting because of the nature of medical conditions. Personally, I much preferred medical calls to trauma calls, not because I was uncomfortable with trauma, but I liked playing detective. I liked asking the questions and finding out what I needed to find out. Inversely, my wife, paramedic also, she loves trauma. She likes the blood, guts, gore. She wants to do things crazy quick and get moving fast. Just different preferences, right? Be strong in both, but you can always have a preference. Now, the condition of a medical patient may not be as apparent in trauma, and treatment may not be as straightforward. Sometimes it'll be more than one isolated problem as well. This is just the overview, like I said. There you can have multiple conditions existing at the same time. Okay, COPD, CHF, those are a common dual finding. They build on each other. Okay, so just keep that in mind. You gotta ask the questions. Ask good questions, get good info, and just understand also, remember also, we're not just asking questions to ask questions. You're not asking questions and getting a response and doing nothing with that response. You now are gathering as much information as you possibly can, with now your job shifting to, I got to decipher this information, and what is the best way, or what is the potential finding I will have from that info that I deciphered. Okay, so that was the medical overview. Like always, like, subscribe to the old YouTube page. Any questions, leave them in the comments, and we'll catch you next time.